Welcome back to Diabetic Foot Files. Today we're going to talk about a condition that is so catastrophic that your own blood becomes a weapon. But that's the whole point of these, knowing all these different conditions and all these possible complications, right? To save lives because I think, I wouldn't say it's one of my pet peeves, but I hate hearing about people dying or because somebody missed something. That's one thing I really don't like. I actually heard another story. It was different. It was a person who deals with dead bodies, right? And pretty much it was a dead body with somebody in their arm was in a cast, and the person died. Of course, that's why they're in the mortuary. And this person, I guess, they show different medical conditions that are causing the death of the patient, right? And the person died from neck gash. The patient had a cast on their arm and died from necrotizing fasciitis. And literally, it was because, yet again, somebody pretty much dismissed their pain symptoms, right? The patient got trauma injury. They put a they gave him some anti-inflammatory, says nothing, and then he came back 2 days later and, said their arm was still hurting, so they put him in a cast, and I guess he died a day or 2 later because he had neck rash, and the person didn't do the right thing, like draw his blood, coulda saw that he had a raging infection. They did do an X-ray, they did not see any gas, they did not see a fracture, so I think that's also why they pretty much just were like, "Okay, nothing's wrong with you," and also they immobilized him because his pain got worse after the first visit, and so they immobilized him in a cast, but the patient actually had neck rash from the injury. So that's the whole point. I don't think people get it. It's life or death when it comes to healthcare, and we have to be able to catch all of it. Okay? Nobody's perfect, but the best you can do is make sure you try to catch all of it. And honestly, the only reason that crash was not caught is because the patient pain, in my opinion, it was like dismissive, The pain was dismissed. Honestly, you can't say, did you do everything you were supposed to do? Because you didn't, right? The patient came back for more pain, maybe do a CT, maybe draw some labs. That's something very simple. Go to the ER, get the blood work, get the labs, see if there's anything else going on, okay? Because the body was trying to tell the person something is really wrong. And their pain was dismissed and they were put in a cast and they ended up dying from neck crash. So that's one of the things. I know people think neck flash is rare, but in the healthcare setting, it's more common than you think it is, and a lot of people miss it, and that's the problem. You shouldn't be missing necrotizing fasciitis, okay? Isn't like it's very non-obvious. It's obvious when it starts raging the body, right? And this is so on a whole different level, but I'm just explaining how important it is to listen to your patient, how important it is to do the appropriate test, how important it is to investigate because I've never seen you can do more good by investigating more and you do more harm by doing less. Okay? I've never seen somebody do better by doing less. Okay? I know how they say less is more, but not in the healthcare setting, in my opinion. Okay? Because people miss too many things and it's not like you miss something and the person it's reversible. No, death is irreversible. Okay. And a lot of things are between life and death. That's why it's a healthcare system, right? It's because our health is what gives us life. So I just hope that's a side note. It was just a little bit of, I wouldn't say rant, but it makes me upset because that person passed away. And, this person who posed the different ways how people die, and this person, I think it's a lady, she recently got this dead body and she was explaining and showing the body and the neck fascia and the fascial planes in the person arm. And it was just like, I was very upset about that because that shouldn't have been. If the doctor was like, go to the ER, let's draw some labs, let's do a CT, they I know for a fact their CBC would have showed something. The white blood cell count would have been elevated completely, okay? I know it would have showed that, okay? So don't just dismiss patients' pain. I've seen too many times people dismiss patient's pain for nothing, and it ends up being a raging infection. That happens also to somebody. I wouldn't even go into it. Let's get into it today. Okay, today we're going to talk about a condition that is so catastrophic that your own blood becomes a weapon. So, disseminated intravascular coagulation. This is not a disease. This is not a diagnosis you can admit on. Like you don't be like, oh, the patient has it, right? It's an actual physiological collapse. It's a chain reaction where a clot forms everywhere pretty much in your body. The organs begin to die, the platelets disappear, and then the bleeding begins. And for a diabetic patient with a severe foot infection, DIC, they use the acronym DIC, disseminated intravascular coagulation, is a moment when limb salvage can turn into life salvage, right? Because it can be a complication. So, what is DIC? DIC is disseminated intravascular coagulation, and it is a systemic, uncontrolled activation of the coagulation cascade. So, it's characterized by widespread microvascular thrombosis, consumption of the clotting factors, secondary fibrinolysis, so there's breakdowns of the fibrin, and bleeding. So what triggers it? So the body releases massive amounts of tissue factor, pretty much factor 3. And this activates the extrinsic pathway. So when it comes to coagulation, there's an intrinsic and there's an extrinsic pathway, okay? And it activates the extrinsic pathway. So the extrinsic pathway, the tissue factor 3, right? It turns into factor, I think factor 7, then factor 10, and that turns into thrombin, and that turns into fibrin. Now, that's happening everywhere in your body. So what happens next? The thrombin explodes systemically. The fibrin strands deposit in the capillaries. The platelets get consumed. The fibrinogen levels drop. The antithrombin and the protein C are depleted, and the fibrin lysis activates, and your D-dimer skyrockets. Okay, so keep that in mind, D-dimer. Okay, and the result is clotting and bleeding simultaneously. Doesn't that sound crazy? If it gives the dog barking in the background, I hope nobody hears that. So, why are diabetics a perfect storm for this? And this, like I said, this is not to scare, this is just to make people fully aware. So, diabetes already creates an endothelial dysfunction, chronic inflammation, elevated PAI1, increased fibrinogen, impaired protein C pathway, microangiopathy, and as severe infection. And now you have a big, what we call a cytokine storm. So, so the cytokine storm includes TNF alpha, IL-1, and IL-6. Not like aisle in grocery store, IL-6. These are cytokines, okay? These cytokines increase the tissue factor expression on the monocytes and the endothelial cells. And the diabetic vascular is already stiff, thickened, and inflamed. So DIC, disseminated intravascular coagulation, does not begin in healthy vessels. It actually thrives in damaged ones, right? And remember, diabetics usually have microvascular or macrovascular disease, right? So, how can a diabetic foot infection turn into DIC, disseminated intravascular coagulation? So, step one, and this is not to scare anybody, this is just for us to learn, right? And be able to know all the different complications so that we can save lives, actually save the life, not say, oops, I didn't know that. Because what do you mean you didn't know that? Right? We expect the person who's taking care of our family relatives or our loved ones to know exactly what's going on and to save their life because it's life or death. Okay, so step one, ulcer forms. So we already know neuropathy that causes from unnoticed trauma, right? So step two, deep infection develops. So let's say osteomyelitis or an abscess. Step three, bacteremia. So bacteremia, gram negative endotoxin release can be gram positive too, but bacteremia. Next, step four, sepsis. So a systemic inflammatory response. Step five would be massive tissue factor release, which will cause a coagulation cascade activation. Step 6, you have DIC, disseminated intravascular coagulation. So, what are some severe triggers in a diabetic patient? They include septic shock, necrotizing fasciitis, osteomyelitis, and methicillin staphylococcus aureus infection, bacteremia. So, what are some procedures that can precipitate DIC, disseminated intravascular coagulation? So, these are important ones when it comes to podiatry and surgical practice for podiatry. But DIC rarely is caused by a routine surgery, rarely, okay? But let's always know everything, right? It's triggered when a surgery occurs in a patient who is already primed for a systemic inflammation. So, what are some high risk procedures that can cause DIC? Major amputation in a systemic patient, aggressive debridement in necrotizing fasciitis, because remember, this is systemic, your body is massively inflamed. Revascularization in a ischemic reperfusion injury, surgery without prior infection control, and massive transfusion scenarios. And the key is tissue destruction equals tissue factor release that will cause a coagulation activation. So, how do we diagnose DIC, disseminated intravascular coagulation? It's quite a pattern. So, the labs that are required, CBC, in the CBC, you're going to see thrombocytopenia. Because remember, we said that the platelets are depleted. A PT, the bleeding time, is going to be prolonged, okay? Because they cannot really fully clot that well. aPTT is going to be prolonged. The fibrinogen is going to be low. The D dimer is going to be markedly elevated. And then a peripheral smear is going to show these things called sheath histocytes. Okay, I know I'm not pronouncing that right. So there is a score, a DIC score, and it's called the IS score. I know I'm not pronouncing right, but I'm just going to say the word, spell it out, ISTH DIC score. So this is based on the platelet count, the D dimer elevation, the PT prolongation, and the fibrinogen levels. And if the score is equal or greater than 5, it's going to be overt DIC. So imaging. When it comes to imaging, imaging identifies the complications, but not DIC itself. So a CT will show maybe possibly organ infarcts or pulmonary emboli. Doppler will show possible limb ischemia. Echocardiogram could possibly show an embolic phenomenon. So let's do a quick little case study. Let's say a 58-year-old male, type 2 diabetes, hemoglobin A1C is 11.2, and I hope everybody understands how big of a deal that a hemoglobin A1C that high is. The patient with a plantar ulcer under the first metatarsal head that has a foul ulcer swelling, fever of 102, and tachycardia. What do you think is going on? X-ray shows gas in the soft tissue. What do you think is going on? Most likely, the patient has necrotizing infection. What are you supposed to do? Emergency surgical debridement is performed, okay? Because we already know that. And what also with necrotizing fasciitis, what is it? It's supposed to be a serial debridement, okay? I've never seen somebody just do it once. You're going to usually have to take the patient again, okay? Because you have to remove all the necrotic tissue. So, post-op day 1, the patient develops hypertension, oozing from the surgical site, blood in the Foley catheter, and petechiae on the patient's chest. So they draw labs because that's what you're supposed to do. You're supposed to draw labs so you can figure out what's going on in the body better. The platelets are 45,000. The PT is 21 seconds. The aPTT is prolonged. The fibrinogen is 110 milligrams per deciliter. The D dimer is extremely elevated, and the creatine is rising. So diagnosis is going to be most likely overt disseminated intravascular coagulation. So what happened? So the severe infection plus the surgical tissue trauma caused a massive tissue factor release, which caused a systemic coagulation and caused also microvascular thrombosis. The kidneys began to fail, the digits began to turn dusky, and this is a thrombotic DIC, disseminated intravascular coagulation, transitioning to a bleeding disseminated intravascular coagulation. So how do you manage it? Immediate ICU transfer. The patient will possibly be put on broad-spectrum antibiotics, source control reassessed, platelet transfusion, fresh frozen plasma, cryo cryoprecipitate, vasopressors, and consider low-dose heparin if there is digital ischemia progressing without major bleeding. And they have to do continuous lab monitoring every 4 to 6 hours. I hope people are fully aware how much we are supposed to do as healthcare providers. If anybody just brushes things off, please find somebody else. If anybody brushes off any symptom that is going on, find somebody else who is going to take the matter seriously because healthcare is serious. It's not something ever to take lightly, and the body's literally telling you something is wrong. Never let somebody downgrade or just dismiss your symptoms or how you feel, okay? Because one thing I do know, especially when it comes to patients, I wouldn't say you're never wrong, but I would say that something is wrong. If you feel like something is wrong, okay? Nobody's telling you to, like, attack anybody or anything like that or say somebody's a bad physician or healthcare provider, but find another opinion if you don't feel like you're being heard, if you feel like you're not being treated appropriately, and also speak up if you think something is wrong, okay? So, let me get back to this. So, they're supposed to do continuous lab monitoring every 4 to 6 hours. So, after aggressive ICU care, so the patient is ICU, they also did a staged amputation. The patient did survive, but they had to do three-toe amputation. That's another thing. We'll get into that when it comes to three tails versus a TMA, but because that sounds like the person will be left with a ram's horn, right? If they were moving three toes, that's what it's going to be very biomechanically unstable. But the point of the matter is the life was saved and the limb was partially salvaged. Okay. So what is the golden rule? The golden rule for DIC, disseminated intravascular coagulation, is treat the cause. If the patient is septic, antibiotics and source control. Don't just come and say, "Oh, we've done all we could." No, have you? Have you? Because honestly, the way I've seen some patients die, or the way even family relatives of mine, I know that the people who were taking care of, especially somebody like my father, I knew they were lazy. They were lazy, okay? They were extremely lazy. They did not do all they could. They didn't know what they were doing, okay? If you can't even get the person's past medical history right, and if you can't really get the HPI right, correct, and saying that people who are dead are still alive and visiting the person, yeah, I don't have any real faith that you know exactly what's going on with that patient's body. And, it ended up resulting in his death, unfortunately, because they didn't know what they were doing with him medically. They were very confused. That was the first time he was in that hospital being treated. But if he went to the States, it would have been much better. They, have better regulations. But, you know, that's something that cannot be undone, but it showed me yet again, because that happened to my grandma as well, that healthcare providers have been just brushing off actual major symptoms that are life and death. It happened to my grandmother. How do you dismiss or discharge somebody who has sepsis? And this happened when I was in grade 5, but I'll never forget it, and it made me wanna go into healthcare. But, I mean, I think it was always in my destiny, but, they discharged her when she had sepsis. Like, you're supposed to draw labs before you discharge a patient, you know? But look what happened. Somebody or a team of people decided to be negligent, and now that person, my family relative, is dead because they did not draw labs. That's one thing I have noticed. If you I've seen more than one time people die because the healthcare provider didn't want to draw labs. It's life or death. Draw the blood, send it to the lab. Let's figure out what's going on inside their body. That honestly, I know it's expensive, but honestly, it should be protocol because I believe that could save a lot of lives. There was a patient and they were in pain. They didn't draw blood because they said, like I said, they said they were one of those people that they call frequent flyers. They didn't draw the blood. The patient had a white count of 56. If anybody can look up what range the white blood cell count is supposed to be, yeah, hers was 56. 56. Yeah. And if they had drawn her blood, they would have saw that she had an infection. But they didn't. They just gave them painkillers and off you go to your home. And what, a day or two later, that patient was found unresponsive, unfortunately. But I'm just explaining that figuring out the underlying cause, source control, drawing labs is a big deal. Figuring out what's going on with the patient. Don't just say, I don't know what's happening. I'm not gonna accept that from anybody anymore because it's y'all. It's people are killing people left, right, and center, and y- these are people, actual people who have families, support systems, people who are connected to them. You cannot bring somebody back to life. Okay, unfortunately, when you make a bad decision because somebody made a bad decision, it's not a mistake, it's a bad decision because you were not knowledgeable enough or did not get what is needed in time. That is not acceptable for anybody, in my opinion, when it comes to healthcare. I'm not going to accept that because, and I'm one person who had more than one relative, family relative close to me, die because of a healthcare negligence. And those people probably still living their life, eating their lunch, having their breakfast, living their life, not knowing that they killed somebody fully, but whatever. So let me continue. The golden rule is with DIC is treat the cause. If septic, antibiotics, source control, support coagulation only if bleeding or high risk procedures are planned. They might need a transfusion, so they might do transfusion for platelets if the platelets are low, below like 50,000. They might need to transfuse if the fibrinogen is below 100 or 150. They might have to use cryoprecipitate, and if the PT is prolonged, they might need fresh frozen plasma. Okay. But heparin is used very cautiously in thrombotic DIC. So, how do we prevent this when it comes to podiatry? Because I'm a podiatrist. So, early warning signs in diabetic foot is sudden systemic instability. Please take it seriously. Unexplained thrombocytopenia, a rising D dimer, run the D dimer, worsening organ function. Here's the thing. Oh gosh. I even once this I think this happened last year. It was like this expensive hospital and it was just like I guess a family friend or whatever, somebody I'm not close to, but they asked me to speak to the healthcare provider and this person had unilateral limb swelling. And the fact of the matter is I'm wondering why y'all didn't run a D dimer. Why? And on top of that, the white count kept on going up and I'm like, y'all not concerned about that? But they scanned the brain. They made sure they did MRI the brain, but the source was the leg that is swelling and oozing and extremely painful. I don't understand. I think people can understand that my patience when it comes to making mistakes with people's lives is quite low. It's a little quite low now. But if you notice worsening organ function, prevent escalation, aggressive early infection control, tight glycemic control, early hospital referral, don't delay debridement, and monitor labs in severe infection. We really should have vascular on that patient. So, GIC, the body loses its balance. It tries to clot, it tries to heal, but the response becomes uncontrolled. And in diabetics, this is where the vessels are already compromised. DIC is not just systemic, it could be catastrophic. And the lesson is foot infections are not just foot infections. People already should know that. They asked us why we needed to learn internal medicine, and I'm like, okay, whatever. But we did need to learn internal medicine because the foot is connected to the body. It's the entire thing. And thank you again, Dr. Zero, for being such a great internal medicine teacher for all of us at CSPM. I really appreciate you. Still can't believe you're on. One of the best doctors ever. Best, 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 best. You know, sometimes the beginning of a cascade that is threatening everything. We have to keep in mind that there are rare occurrences. You ever watch that show Mystery Diagnosis or that lady who does the autopsy report on people? I That is a pet peeve of mine when people miss it, especially when people go to healthcare providers and they miss it. That's a pet peeve of mine because and it's very interesting to see the ones that are saved by people who were like, "Oh, I double checked and then I remembered there was this one rare diagnosis, and I'm like, "That is so cool that that physician or healthcare provider was able to figure that out." But when I see that they miss it and the person dies and everything, that and usually it's over something very obvious and very simple. You could have figured it out. And that it definitely is a pet peeve of mine. If you didn't draw the labs, okay, if you didn't draw the labs, I'm sorry. The fact of the matter is I get it. You don't want to cost more, less is more, but honestly, less it can also cost a life. Less can also cause a life. That's that's the fact. Less can also cause a life. So sometimes it's better to do more to figure out exactly the underlying cause because that's the whole point of being a doctor. You're supposed to know why. Why there is any type of imbalance in this patient's body and how can we save their life? Why and how? Okay? Not oops. Not oops. Nobody's Britney Spears here. Okay? So let's just try to do best and always save a life. So this is Diabetic Foot Files. I'm Dr. G, and take care of your feet because they take care of you. And I hope everybody found this interesting because it's a complication and we should know about it. So yes, it's Diabetic Foot Files. Take care of your feet because they take care of you.